So with that, let's get started. I am so happy to introduce 6 experts who will take us through today's program. Shelley Lyford, President and CEO of West Health, the Gary and Mary West Foundation, and the West Health Institute is here. We have Kim McCoy-Wade, Director of the California Department on Aging. Tim Lash, Chief Strategy Officer at West Health and President of the West Health Policy Center is here. As is Bob Blancato, President of Matz Blancato and Associates and this year's ASA Hall of Fame Award winner. We have Dr. Stephen Starks, Clinical Assistant Professor at the University of Houston College of Medicine. And we have Maureen Allen, healthcare consumer, writer, copy editor, and proclaimed horsewoman. Panelists, welcome to On Aging. Thanks for being here. And now it's my pleasure to introduce Shelley Lyford, the President and CEO of West Health, the Gary and Mary West Foundation, and West Health Institute. Shelley leads these organizations as they use a combination of applied medical research, policy, advocacy, and outcomes-based philanthropy to lower healthcare costs and improve healthcare for older adults. West Health has been a tremendous partner to ASA over the years, contributing to our publications, our podcasts, even to our board of directors, and of course at our conferences like this one today. Shelley, thank you so much for your continued partnership and for today's excellent program. With that, I'll turn it over to you.
Great. Leanne, thank you so much. And thank you all for joining us today and for your dedication to improving aging in America. It is a pleasure to be with you, albeit virtually. And I look forward to when we can be together again to collaborate, to work together, and to learn from one another. So if you haven't already done it, please get your vaccine. No one could have predicted the hardships that we would face since our country began fighting the virus in March of 2020. Every single one of us has changed in ways both told and untold, seen and unseen. And more than anything, we have all learned to be adaptable in the face of the challenges COVID-19 has brought to us. And at the same time, for those of us who have dedicated our lives to improving aging, it has been a frustratingly hard and sad year. We've watched older adults suffer at the hands of a system that has failed to plan and prepare for their needs and safety. Beyond the staggering death toll, the coronavirus has magnified issues that many older adults already faced: isolation and depression, financial insecurity, navigating a broken healthcare system, malnutrition, and the list goes on. And while it has been painful to witness these failings so publicly and en masse, the silver lining is that the challenges facing seniors have been illuminated for all Americans. Perhaps the COVID-19 pandemic could be the wake-up call we have been waiting for. Since March of 2020, the senior experience has been front page news. At dinner tables across the country, families are more openly discussing aging with their parents and grandparents. In state houses and in our nation's capital, the needs of older adults have gained attention. More than any other time in recent memory, our society is confronting the difficulty of aging in America. How we age touches almost every aspect of society, from housing to transportation, to nutrition, to healthcare, and even to how our families are structured. The results we seek will not happen overnight, but progress is possible. It is up to us, the people who live and breathe aging issues every single day, to lead the charge. We have an obligation to make sure that our society and systems are better prepared for the future. Yes, it's going to take planning, foresight, and creativity, and I am proud that many solutions are already in motion. Take, for instance, the advances we have seen this year in broadening the use of telehealth, increasing and improving care in the home, and the work being done here in my home state of California to create a master plan for aging, a comprehensive, decades-long plan that retools what it means to age successfully. This plan demonstrates that we must be willing to think big and solve problems differently. The challenges we face are too complex to be solved by any one person or entity. We all have a role in shaping successful aging in America. In today's session, we will talk a lot about California's plan and ways to improve the healthcare system to be more affordable and equitable for seniors and all Americans. Values of affordability and equity must be central to our work, not simply during this period of COVID relief and recovery, but as fundamental pillars of our senior support system and society at large. Before I turn it over to one of the architects of California's Master Plan for Aging, Kim McCoy-Wade, Director of the California Department on Aging, please join me in watching a brief animation about the Master Plan and the progress that we have made in a state that boasts the 5th largest economy in the world and is home to one of the country's most diverse populations. Thank you.
Over the next decade, America will experience a major demographic shift. By 2030, 1 in 5 adults will be over the age of 65. In many ways, America is unprepared for the changes in our society as it grows older. There will be exciting new opportunities as well as new challenges. From coast to coast and in the rural pockets and bustling cities, people are aging differently. Too often, the aging experience is determined by zip code and income. Scarce resources are fragmented. Some services are duplicated, overlapping at the federal, state, and local levels. In other areas, gaps grow due to lack of coordination, and everyone, including caregivers, needs better support. It's clear we need a plan. In California, for example, the over 60 population is projected to grow to 10.8 million by 2030. California seniors are increasingly likely to live alone, work longer, and have lower incomes with little or no retirement savings, and many are in debt. These realities expand the need for state and local services. In 2018, the Gary and Mary West Foundation and others activated Californians to encourage the state government to take action. As a result, gubernatorial candidate Gavin Newsom placed aging at the top of his agenda. In June 2019, Governor Newsom issued an executive order calling for a master plan for aging and establishing the Stakeholder Advisory Committee comprised of advocates, academics, aging experts, and more. For over a year, the Stakeholder Advisory Committee and California Department on Aging gathered input from government, local communities, and the public. Their effort produced a comprehensive 10-year blueprint to create a California for all ages and stages of life. Released in January 2021, the Master Plan for Aging outlines 5 goals and 23 strategies with solutions that span the senior experience. It includes over 100 action-ready initiatives to begin now, a data dashboard to track progress, and a local playbook to drive on-the-ground partnerships. And this is just the beginning. California's plan is meant to be a living document, updated over time. But what about older adults outside California? In 4 other states, similar plans have been initiated. These, along with California's master plan, could serve as a model of best practices for the federal government to emulate. While there's no one-size-fits-all solution, with a coordinated national plan, we could improve the aging experience in America for generations to come. We all deserve to age well, with access to high-quality, affordable health care and support services that preserve and protect dignity, quality of life, and independence. It's time to get to work. None of us are getting any younger.
Kim, welcome. I'm so happy to have you join me today for a 20-minute conversation regarding the Master Plan for Aging. Kim, when work began on the Master Plan well over a year ago, who could have predicted a global pandemic that would upend our lives and take an outsized toll on seniors across the country? Obviously, that wasn't part of the plan when we started, but it certainly couldn't be ignored. Kim, talk to us a little bit about how COVID-19 impacted the master plan?
Thank you so much, Shelley, and thank you for that wonderful introduction in your words and in the animation. Kudos. Yes, COVID affected the plan in so many ways. I mean, first and foremost, we had to pause the work. We had to all pivot March 15th when the stay-at-home order came for older adults, and shortly thereafter, the whole state. We had to pause and just go right to COVID response, right? Everyone knows our meals had to go home delivery, our adult day health had to go remote. So we were really focused on that immediate response. But as we reconvened around Memorial Day, it really called on all of us to double down on the issues that we knew and the gaps around healthcare, around home care, support for family caregivers, isolation just became even more urgent. And frankly, as the pandemic persisted in the terrible case and death rates, particularly in California, nationally, the Black community, Black elders, Latino elders, certain Asian Pacific Islander elders, the equity work became even more front and center. We were very fortunate. Our stakeholders had called for an equity committee to be added in December. So it was the first group to reconvene when we got back to work after COVID and really elevated the work to do more and do it at that intersection of age and race and justice.
That's right. Kim, and from your perspective, Kim, what kind of light did COVID shine on the fragility of our systems?
Oh my gosh. Well, where to begin? I think the first stark light was what was happening in congregate living, in nursing homes and assisted living with the wildfire, if I can use that metaphor, in California, of infection control and terrible, catastrophic death rates. So that issue of how can we reinvent, reimagine congregate living, make sure only those who need to be there are there, and those who are there get the very best care. But increasingly for folks, it's about living at home in the community. And how do you do that healthily and happily? So we saw lots of folks trying to figure out how to get food, trying to figure out how to get the home care, maybe needing a new home modification. We also saw people really, one of my legislative allies says, gosh, I have in-laws who are online and I have parents who are not online. And the difference of the pandemic experience not being online, whether it's social connection, healthcare, just the digital divide for aging was a huge, huge piece. So we know there's more to do there. I have to say ageism, I have to say it, we saw it too often, even in well-intentioned benign ageism, all about the vulnerability and not about the resilience of older adults. So there were just, I could go on and on and on, and I would be remiss if I didn't talk about family caregivers. Our cabinet work group, all of the 10 secretaries serving our governor, Gavin Newsom, I think almost all of them are some sort of family caregiver, if not an older adult themselves. And those stories were always front and center when we convened. How do we support families who are honored to be doing the care, but are also finding it incredibly challenging? So again, every issue that the analysis and data had shown us before COVID, people were living with new intensity and urgency in COVID, and it just accelerated our need to respond.
Absolutely. So Kim, as a member of the Stakeholder Advisory Committee, when we reconvened in May, hearing the stories and learning about the ingenuity and what different communities in our state were doing to pull together, to create solutions, to break down boundaries, that was so enlightening for me. And I felt like it shined a light on the importance of the master plan and the fact that coming together was even more important. And so I think that's going to segue to my next question, Kim, around the origin and the details of the master plan. So while the master plan for aging is the product of many heads coming together, what do the origins of the master plan say about the power of advocacy, grassroots efforts, and community-based organizations?
Absolutely. I'm very proud that we spent over 18 months after the executive order. The animation reminds us the work began well before the executive order. So thank you for that important reminder. But I'm very proud that we had, although it was very challenging, we had probably over 100 people on formal stakeholder committees. We had a dozen roundtables out in the community with legislators. We had a handful of corporate roundtables as well with the tech sector and with long-term care insurance sector. We had public comment. And frankly, when we went remote, even more and better and more diverse, particularly from older adults and people with disabilities from the southern part of the state, mountains, deserts. It really opened up our participation. We did surveys, we did town halls. So all of that meant that we received in September, more than 800 recommendations from the stakeholder committee, which was just extraordinary to have that gift for the cabinet to process. And as you said, come up with a framework of 5 goals, 23 strategies, and 100 things to do this next 2 years. And now, 3 months after our launch, I mean, we launched in early January, where you may recall there was a lot going on. We had hundreds of people attend our launch and then our summit with our cabinet secretaries and legislative partners and stakeholder partners to roll it out. And now I'm very pleased to say we've got trainings on the local playbook with county board of supervisors from all over the state. We are working with the AARP network of age-friendly communities on the local playbook. And the stakeholders have created a tracker of all the legislation that is tied to the master plan for aging and all the budget proposals that are tied to the master plan for aging. Because as you said, well, the plan is just the beginning, and now we have to take all that inspiration and put it in, turn it into that perspiration and sweat equity to make it drive real change in people's lives.
That's great. So I love your saying, and I've heard you say it before, inspiration to perspiration, because that's what it is about. And I was part of all of that energy and inspiration, for the past 2 years. And I'm so proud to be at the Gary and Mary West Senior Wellness Center when then candidate Newsom signed a pledge that he would make aging a major platform of his administration. And he delivered on that promise with signing the executive order. So I'm so pleased to be part of and supportive of an administration that follows up and does what it says it's going to do. Kim, you just outlined so beautifully kind of the origins of the plan, and you walked us through some of the plans and how we went from 800 great ideas to a series of 5 goals, 23 initiatives, and then 100 or 23 strategies and 100 initiatives that we're going to get to work on right now, and that will have something to where the rubber meets the road over the next 2 years. But can you talk a little bit more, Kim, about the principles behind those 23 strategies and the 100 initiatives, and kind of what is the most significant aspect of that, and what do you think will be the new programs that will be created coming out of the plan?
Sure. So we were very clear that we needed to reflect the values of our administration and agency, which have to do with being person-centered, data-driven, and equity-focused. And those 3 things, we kept holding ourselves up to it. And again, our equity work group and our stakeholders and our legislature all kept asking us too, can we see ourselves in there, the diversity of California? Are you talking about systems of care, not programs and departments? Are you really talking about elder justice and home and community-based services as a whole system? The data dashboard you mentioned, we're so thrilled to have a person-centered dashboard about real outcomes. Are we preventing avoidable falls at home, for example? And equity at the center, all of our metrics looking at race and age and where we can, LGBTQ plus and disability, although we have more to do on data source there. And talking about closing those critical equity gaps in affording aging, in life expectancy. The gap is going to be worse coming out of COVID, we all know, and we have to do better, build back better. I think one of the major policy focus, and there are many, and there's a reason housing in California is the first goal, but the housing to health connection, the health and housing bridge really was one of the centerpieces. I don't have to tell this audience about the gaps in Medicare, helping pay for home community services, the gaps in Medicaid in parts of the state, in parts of services, parts of service continuum are really critical. So at the center is this question of how do we make care at home affordable, accessible, quality, driven by the consumer. I'm really excited by the chance to break through in California. We're looking at Washington, what they've done with their state LTSS benefit, looking at that very closely, and also looking at what we can do in California. We're proposing a new office of Medicare innovation and integration to make sure we're leveraging the full Medicare tools and dual tools. We are moving towards a statewide system of managed LTSS, but from where we sit in aging, just as important as that healthcare access are the social pieces of care there. So my department's looking at that no wrong door system to make sure you're connected to community. And of course, we're very excited about the geriatric emergency department model, which I have to say, when I first learned about it, I saw the clinical advantages. Oh, great. We have people who understand multiple prescriptions and who understand mobility and dementia screening. That's wonderful. But it is so much more than that, as I've come to learn and see. And, our tour was about to be mid-March, right? So we have to get that tour back on the calendar, Shelley. I'm vaccinated and know you are too, so we'll get that tour back on the calendar as soon as it's safe. But that fact that model assesses for how is your nutrition? How is your housing? How is your family caregiver? We look at the whole picture. And I was just talking to my colleague in social services this week, and we also can be we are a critical detector for mistreatment, abuse and neglect of various kinds. And so how do we not just hit that crisis, but really see it as an intervention to bring that full care that we know is the key to healthy aging. So I'm really excited to make progress on all those pieces: access, affordability, coordination, and then that prevention and support for a long and healthy life at home.
Okay, I love what you said. You talked about the social determinants of health, how everything is connected. Healthcare happens outside the four walls of the hospital. So incredibly excited about what we are doing at West Health, working with the state of California on that initiative that you just said. 100 great ideas, 100 initiatives that are going to happen within the next 2 years. Having a statewide geriatric emergency department network is something that we are focused on and we're excited about implementing, which, as you just said, is so much more than just emergency care. So Kim, you talk about all these great ideas. My heart's racing a little bit because it's so good. It's what we need to do. It's the right thing for California. But talk to me about the money. We got to follow the money, and we have to be able to fund all of these great ideas. As we were creating the master plan together and we're coming up with all the ideas, I think we also had this very pragmatic, we stayed in a pragmatic lane saying, listen, none of this is going to happen unless we can fund it. So talk to me about budget, the state of California budget, about public-private partnerships, and how we are going to roll this out over the next decade.
Absolutely. So we have been spending a lot of time on the money recently, since we began the launch in January, on every level, the state, the federal, and the private level. So I would say on the state level, we were very pleased the governor's budget did include aging investments in a couple ways. One, in our big ticket priorities in California, housing and health, aging is clearly layered in. $250 million to purchase vacant assisted living facilities and bring in folks who are at risk of homelessness. Again, a really terrible crisis in California is the rise in elder homelessness, and the plan commits to ending it. And you also see it again in the health proposals I talked about. But also there was a long series of specific healthcare investments, everything from geriatric pipeline development at our health planning department, a package of Alzheimer's investments with an equity lens at our public health department, the No Wrong Door at our department. Across the departments, you saw aging get prioritized in some ways. And I'm very pleased you just saw the close budget watchers in California just saw the new spring updates. More dollars for our state health insurance, our high cap Medicare counseling program, more money for master plan and aging implementation, and importantly, a first ever governor's special advisor on aging, disability, and Alzheimer's. So more is coming in all those ways. And, again, in California, we've got both people in great need and people with great resources. And so the state budget picture is very positive, but more than that, the federal picture. We have been very, very, our network has gotten incredible support so that we have record numbers of meals from Older Americans Act funding and now the American Rescue Plan. Another wave is coming to help with vaccines for older adults with disabilities. We are trying to make strategic investments in not just food and information, but digital divide, rolling out new purchase partnerships with broadband, a behavioral health hotline, the Friendship Line California, in partnership with Institute on Aging. So the federal resources have been great. We're watching the home community-based services investments real time to be a game changer. And of course, the new care economy proposals in the infrastructure bill that the president has proposed. So I do think it's a generational opportunity for our network. And then last but not least, I am working with the 8 foundations who were the initial partners to really make this possible. We would not have been here without 8 foundations in California saying, yes, we will help support the development team. And we've come up with, I don't even want to count, Shelley, but dozens of potential philanthropic investments, both already underway and potential. And we're looking at our governor's office of doing a funders briefing to help bring in more of the philanthropy community. We know the philanthropy dollars don't yet equal the population graphic we just saw. And so how we can do more to bring in those private partners as well. So yes, federal, state, local, public, private, health, social, everyone's got a part in this. And we're really pleased to be pulling together.
Excellent, Kim. And just to build on what you just said, I agree with everything you just said, and I love the framework and all the different swim lanes that you outlined. How can we assure that this decades-long plan is going to transcend administrations?
That is a great question. I think the good news is I'm actually not that worried about that, because I think aging is having its moment. I think it was having it before COVID, and I think there's no going back after COVID. But even with that optimism, I think it's the stakeholders in the legislature and the administration and the teamwork who are going to carry this through. California has done master plans on higher education, and we have a track record of carrying them through. I'm very much looking forward in coming weeks, I won't say days, coming weeks, to announcing our oversight committee, our board of directors, if you will, which we're calling the Impact Committee, implementing the Master Plan for Aging in California together. And that group will have that 2-year mandate to say, how are we doing? What did we get right? What did we miss or need to update? And what's the next thing to do for the next 2 years? So we're hoping with that 2-year accountability cycle, we can both make meaningful progress and then also have an opportunity to continually learn and adjust, because the world is always changing, and we know we can need to meet the moment over and over again.
Exactly, Kim. I agree with you completely. And I think the most important thing is accountability. And between the data dashboards where we are measuring impact and the accountability of the Impact Committee, we will be able to transcend administrations. And something that I love to talk about is living is aging. Every day we live, we're getting a little bit older. And what is good for an older American is good for everyone. And so, like you said, I am very optimistic that this is going to transcend administrations, transcend states, and hopefully move on to a federal level plan. So, Kim, we just have about a minute or two left. As we're wrapping up, speaking of moving into other states and perhaps having an opportunity at the federal level, what do you think about replicating California's master plan into other states or even something federally?
You know, I think the stars are aligning. We're starting to get a critical mass of states with master plans or in the AARP network. Certainly the demographics are there. And again, that COVID experience has just shown such a spotlight, again, not just on aging as an older adults issue, as a whole family issue, a whole community issue. I mean, family as we do in California, small f, family of choice, right? Our circle of loved ones. So I think there's a huge opportunity. We're very lucky in California. We've got some of the key leadership. Our vice president, as well as our confirmed Secretary of Health and Human Services at the national level, and on her way, our labor, so Secretary Becerra and Julie Sue. And of course, you need that caregiving workforce, the Health and Human Service Partnership. We're excited by the leadership so far at the Administration of Community Living. So I would say to the feds, some of the work they've done on elder justice is inspiring us at the state, but I think it is a moment where you could see the kind of cross-agency, cross-department, cross-state leadership. And frankly, with the amount of resources that are being provided to help us all recover and build back better, that kind of national leadership would be welcome. We wouldn't be where we are in the vaccine recovery without the federal-state partnership, and I think we need that for the true vision for an age-friendly nation going forward.
Kim, you are an inspiration. Beyond an inspiration, you are an implementer. So I love a person who's got the vision and then can roll up their sleeves and get the work done. Thank you so much for joining me today, Kim, and thank you for providing your very important perspective and for everything that you shared with our audience.
Thank you, Shelley. I look forward to seeing you on an implementation call very soon. Okay. I look forward to the discussion.
Great. So I am now delighted to introduce our next panel, led by the president of our policy center, the West Health Policy Center, Mr. Tim Lash. Tim and his guests will discuss the burden of high healthcare costs on older adults and all Americans. There is a direct link between the America that Kim and I were just envisioning and affordable, quality healthcare. As a society, we cannot age successfully when we are living in fear that exorbitant healthcare costs could prevent retirement or even wipe out a lifetime of savings. Tim, my friend, the floor is yours.
Great, thanks, Shelley. What a great discussion with Kim. You know, I think when we think about healthcare and we think about aging, these concepts are obviously inextricably linked. And you know, from my perspective, and I think we'll see as we engage in this panel discussion, the discussion is very different for different reasons. And when we think about the master plan in California, there it was, an early commitment and, it was a vision of the governor and administration, the support of the foundations and engagement of other stakeholders, community-based organizations, et cetera, that really drove that forward. There's still work to be done, as we've heard. Funding is obviously very important. It needs to be nurtured and cultivated and ultimately supported. But the discussion is clearly changing. And I think, when we look at healthcare costs, that discussion is changing as well. And I think when you try to navigate, an evolving environment, it's really important to understand, so why is it changing? And I was flying back from DC the other day, and I was thinking about this, and I think it's easy to say, well, it's because we had a pandemic. Right, and that the pandemic caused this evolving discussion, this urgency around healthcare costs, this urgency in addressing equity issues, this urgency in addressing access and outcomes that are a result of our healthcare system and often less than ideal. And as I thought more about it, I realized this isn't the only pandemic that we're facing. In fact, there's pandemics across the country when you think about healthcare at every turn, right? So let's just break some of those down, right? When I started my career in New York, rode the subway a lot. Certainly at that point, I didn't realize that just in a 30-second or 1-minute subway ride, you could witness changes in life expectancy, right, between communities of 10 years, 15 years. You stay on that subway, a few more minutes. And you're now have contrasts of up to 2 or 3 decades difference in life expectancy between these communities, right? That's New York. That plays out in Boston, Chicago, Detroit, every metropolitan area, every diverse community across this country. That feels like a pandemic to me, right? Or certainly a problem of pandemic proportion, right? And that's not a new problem. It's been there, and yet even with that contrast, we still haven't been able to navigate, sort of very meaningful change on the healthcare front. I think about prescription drugs, and that's a topic that we're going to talk about a fair amount today. At West, we just did a study looking at the Medicare population. So you would think that, Medicare recipients who have, Medicare Part D, so they have prescription drug coverage, that, they would have pretty good access to prescription drugs. What we found is that in the Medicare population, there's a significant portion of people that are not adherent. That means they're not taking their medication because of cost. They just, they have to make very difficult choices between the cost of food or the their housing, or even, or even other healthcare costs, and it causes them to be less than adherent to their prescribed prescription drug regimens. Well, when you look at the result of that, it's not just that you have worsening chronic conditions or worsening health. Annually in the US, there's over 120,000 seniors that die because they can't afford their prescribed prescription medication. That's over 1 million people every decade that are no longer with us because the cost of prescription drugs are just too expensive. And there too, I would opine that is a problem, of pandemic proportion at minimum. And if you think about sort of cost and toxicity and mortality, I'd say that's just a pandemic, sort of as well. And there too, for a variety of reasons, we failed to make significant progress in addressing that. And, one of the key reasons for that is, and, this, I think COVID, puts a little bit of sort of tailwind behind this, is this, this fallacy that we need the cost of prescription drugs to be so expensive because it supports innovation. And that also just doesn't hold water. That's not the reason. We did a study, in collaboration with Extenda. It's a division of AmerisourceBergen, and it's one of the partners of the pharmaceutical industry for health economics research. And what we found there is that you could strip $1 trillion out of the sales of pharma over a decade, and it would still be the most profitable segment of our economy as measured by return on capital invested. So, again, we don't need these high prescription drug costs because it supports innovation. We have people that are dying, and yet we've not been able to make significant progress. So what has changed? Like what has COVID caused that is now really changing the discussion? And I think it was appropriate that I was on a plane when I was thinking about this, because for most of us have flown, and when you're flying, you're going quite quick at 35,000 feet above the ground, 500 plus miles an hour, but yet it feels like you're standing still. And I think that's sort of an insight into how the discussion is changing, right? This concept that if you have high velocity, you can have lots of people dying or big pandemics, but they've been with us and we become desensitized to them, much like on a plane. When you're going, take off, you feel it, but when you're cruising, you become desensitized to the fact that you're moving so quickly. And with COVID, because it hit us so quickly and it hit the population sort of, every corner of the country with such high change in velocity, right? We went from, it's like taking off on a plane, right? That people immediately became sensitized to it. And the reason that I focus on this as we transition into the panel is because if you don't understand why things are different and why the discussion is evolving the way it is, it's really difficult to navigate it to make sure that you have sort of the most meaningful change come out of it, right? And I think what this tells us is that lessons learned from history is if we don't seize this moment right now, where we just experienced this very rapid change in velocity that caused people to focus up on this problem, that we'll go back to the subway model of the discrepancies in mortality, to the deaths due to non-adherence, to the impact of the existing fractures and flaws in our systems on sort of human outcomes. We'll become desensitized, just like we have for many of these other pandemics, I would say, that have plagued our country and, in fact, sort of the broader, world society for many decades. So it's this change and this moment. The discussion is different, but we have to capture the moment today because it will be fleeting in terms of the window open to drive significant reform. So with that, I want to turn to the panel. I'm really excited that Stephen and Maureen and Bob are joining. And Bob, I'm going to start with you for an inside the Beltway question, right? Is the discussion right now within Congress a different discussion? And if so, do you agree that that the opportunity might be fleeting if we don't capture this sudden change in velocity in terms of the impact?
Thank you, Tim. And I would agree with you about the seizing the moment, the opportunity that's there. There's an old saying about hope springs eternal. There's also a saying the more things change, the more things they don't change. And you deal with Washington, the urgency piece has been reflected in the immediate passage of the American Rescue Plan. Okay, that was a very important development that where there was, even though it was a partisan vote, ultimately, in the end, it got done because the urgency was associated with the needs that were there. And I'm glad Kim raised that point in her comments, and she's right. But the real testament will be what happens in the next bill, in this infrastructure package. Okay, because here is where you're talking about more than just responding to the crisis of the pandemic. You're dealing with investments. And I would argue, as the wonderful advocates that the West Health folks are, we as advocates need to be loud and clear that the $400 billion that's being proposed for home and community-based services and the workforce is an infrastructure issue. Let's not get caught up in semantics. Is it a road or a bridge, or is it an investment in the workforce and home and community-based care? People are going to argue in Washington that let's not spend money on it. It's not relevant to infrastructure. It is. And it is very important, particularly in this COVID environment, where we see the shortcomings in the workforce. We see the shortcomings in access to care. So it's very important that we take this opportunity and move the needle on this bill. And I think this is going to be a real testament to how things have changed in Washington. If we can get this bill through, then I think we're going to be looking at a very more positive environment.
But beyond this bill, do you see other windows open for more meaningful sort of reform? I think about the reform of prescription drug prices, potentially sort of Medicare negotiating as a pay for some of the other sort of infrastructure or investments that are necessary. We're facing an updated report on the trust fund, the Medicare trust fund that's looming ahead of us. It's unlikely to paint a rosy picture in terms of solvency moving forward. What are some of the other windows that might be open in terms of more significant structural reform?
Well, I think, the first one we have to see is the one I just spoke about. I mean, there are people in Washington who want to use healthcare pay-fors, such as the prescription drug, the HR 3 and Medicare negotiation to help pay for the investments on infrastructure. There's also talk about waiting till the fall and have a large healthcare package put together that'll address a range of issues involving Medicare, Medicaid, and so on. So the picture is not 100% clear what the timing is going to be, but at the very heart of this discussion will be lowering the cost of healthcare. It will be there because you've got numbers that are staggering that talk about, not only what we're looking at right now, but when you look into the future and, numbers that have been put out there to talk about how much of the GDP is going to be consumed by healthcare as soon as 2017, those are staggering numbers. And so the problem that and a lot of people know is that when you use when you think about Washington and Congress, the word foresight does not jump out at you. And sometimes you wait for the crisis to be at the doorstep and then you move on it, okay? When you talk about healthcare costs, this is not a new issue. It should have been addressed before, but now we've got to be looking toward the future. And I think your point about the trustees report, I think is going to be perhaps the most motivating thing that happens because it's going to paint a picture that's going to almost mandate reform get done.
Bob, do you think, healthcare tends to be a very partisan issue, right? And we're seeing this right now, when we look at Medicaid expansion, right? In states that have, that have expanded Medicaid programs, right? We've seen very significant progress on addressing, some of the inequities that transcend, our healthcare system. And yet, we have this partisan divide on should we, continue to expand when we know that it works. Do you think that, our elected officials really understand the pain points, for individuals and families in terms of the consequence of this expensive system and the consequence of the pervasive equity issues that exist?
No. If they do, it's taken a long time for it to be registered in the way legislation's passed. But I will say that you use Medicaid as an example. One of the old concerns about Medicaid was that it was spending more of its money on the people who needed the 5% of older adults that were in nursing homes were getting a disproportionate amount of Medicaid funding. Okay, now more money is spent on home and community-based care than institutional care for the first time in history, and that started about 3 years ago. Why is that? Because people put pressure on people in Washington saying that's what we prefer. That's what the older adult prefers. That's what the family prefers. So now you see that change happening. And what we have to get done, in fact, it's so successful that we have waiting lists now of significant number in home and community-based care that the president has committed to getting rid of and to reducing and eliminating. So I think as time goes forward and people begin to see the benefits of Medicaid expansion, and now there's new incentives to do Medicaid expansion where it hasn't been done, there may be a greater understanding about Medicaid going forward. But I think Medicaid is the barometer of making health equity changes. That's really the key program. If you can make changes there, you could really make a difference in health equity going forward.
Bob, it's striking that, in sort of this year, given what we've just experienced with COVID and given sort of the pandemics that sort of, I opined on in the beginning of this panel, that we can still have a Congress that's blind to the consequences of these high costs. And so I want to put a face on this. And Maureen, go to you to talk a little bit about, what exactly is the individual experience in navigating this high cost system? I think we might be having some technical. Maureen, are you there?
Yeah, she's on mute.
Okay. Well, while we wait for maybe the ASA can help with the mute issue. With that, Stephen, I'll go to you while we're waiting for Maureen. As we think about sort of responding to these sort of challenges, the window's open for some legislation. We've sort of touched on some of these sort of equity issues that exist. Can you help us, think about a framework of some of the non-negotiables that need to be part of sort of healthcare transformation and regulation and legislation moving forward?
Yeah, so I think with this Congress, we can maybe kind of take a look at some of the efforts on the healthcare front with the previous Congress. So the 116th Congress, the big thing that we were aiming for at that time was, again, kind of regulating and trying to make attempts to lower healthcare costs, and primarily through looking at the cost of prescription drugs. So we do know that that's a substantial burden for many older adults and all Americans. Really. And we also do know that there are differences in terms of the equity issues that you kind of noted in terms of race and ethnic disparities that also exist. We know that 1 in 4 Americans had reported that a family member didn't fill a prescription in the past year. We know that 1 in 4 patients with cancer were taking less or not filling their medications as often. And we do know, again, about the kind of extremely increasing drug costs that were happening annually, specifically for brand name medication, specialty drugs with little or no competitions. And there's obviously a lot of reasons why there's little or no competition, because the incentives don't justify such. And we had heard a lot of issues that people had with specialty drugs, affording them. And insulin was always the example that was kind of brought up on most often occasions because of its exorbitant prices that have increased or nearly tripled within 7-year periods of time on end. So I think there are opportunities for us with this Congress to move forward to promote equity, to promote increase access and affordability, specifically of prescription drugs, but hopefully in other arenas as well.
So, Stephen, when you think about, just think back over the last 10, 20 years, right? Again, these equity issues, these are not new, right? This wasn't caused by COVID. And I'll go back to this velocity issue. When we think about, diabetes, heart disease, right, have much higher prevalence, right, in Black and brown communities compared to, to other, segments of our population, right? And the consequence of that generally plays out over decades, right? Where you see differences in life expectancy, over a 10-year, a 20-year period. These same conditions, heart disease, diabetes, et cetera, right, conferred a much higher risk with COVID-19. And there we saw the impact of these inequities and the higher rates of some of these comorbidities play out over days and sometimes hours in terms of separation of these mortality curves, right? So much higher velocity in terms of the or change in velocity in terms of the impact. How can we make sure that as we're thinking about reform within this Congress and within this administration, that we don't go back to where we were, that we witness, that it was pervasive before. We've shined a light on it in a very new way, but there's a timing issue, right? If you don't act quickly enough, it just goes back to a problem that is more opaque.
Yeah, as you were actually framing that question, it made me think about our path in terms of social justice issues. So if you look at healthcare itself in terms of its progress since the Civil Rights Act, which kind of was the first ball in kind of getting a first kind of a piece of legislation and policy that actually started to promote desegregation in hospital systems. And if we also look at the initial Medicare Act and the Social Security Administration amendments that promoted desegregation in hospitals, and if we think about kind of the more knowledge that we've had about issues of equity, I think it's important, and there's a concept out there that describes syndemics. So a pandemic is not only kind of tied to those pre-existing conditions that you identified in terms of heart disease, diabetes, hypertension, lung disease, et cetera, but also really kind of recognizing that there are economic issues, there are issues of structural racism that are at the heart and core of those matters. So when we look at the disparities that we see with the Navajo Nation, or if we look at the disparities that we see in Black communities across the country and Hispanic and Latinx communities, I think it's important for us to tie kind of healthcare to other economic and social justice policies that are out there. So whether or not that's educational attainment, which we know there are differences in terms of health outcomes based on education. If we look at safe housing, if we look at food and nutrition policies. So I think collectively, looking at those collectively will help us to better achieve kind of progress on the health front. I think all too often we oversimplify those racial and ethnic health disparities to just focus on healthcare. I think it's complicated in our Congress because our committees are designed in a way that kind of segregates overlapping issues. But I do think it's important for us in some way to bridge that gap between the economic, social justice, and health equity issues. That's a part of our American history in terms of kind of its evolution over time with civil liberties, social justice movements. And so I don't think that's going to be any different now than it was in the 1960s or 70s.
I couldn't agree more. These are the incentives aren't often sort of aligned, right, to to profit motives, et cetera, right, to drive some of these meaningful sort of reforms through. And the more that we can sort of expand the armamentarium, the number of tailwinds, right, the number of reasons to act, I think the higher the probability that meaningful change happens. It's hard though, right? We look at you mentioned education. 30 plus year difference in life expectancy when you compare sort of the bottom 5% of those educated in this country to the top 95%, the 5% on either end. And yet we still have, all but one state spending more on healthcare than they do on elementary education, right? So these concepts are linked. I think one of the most powerful forces, and Bob, I appreciate your sort of directness on this, is that the Congress needs to understand the human impact, the personal experience, the family experience that is the reality for so many. And I think Maureen is now off mute. And Maureen, I'd love to go to you just to talk a little bit about your own experience navigating healthcare and what it's meant for you and your family.
Thank you, Tim. My experience with healthcare is that I have a probably terminal case of what you described as painful trade-offs. I had no idea that anyone else had thought of the solution, but apparently they have. You just skip other stuff. You skip meals. You skip other meds. You skip doctor visits, dentist visits, whatever. The medication that I take for a DVT and pulmonary embolism is extremely expensive, to the point of about a quarter of my Social Security. Well, I didn't work 60 years to spend that much of my disposable income on this medication, but I'll die if I don't take it, so fine. But that means other sacrifices, and I'm willing to make them because I believe most strongly that this is my time to make the dreams come true that I couldn't before because I was working, and I'm not giving that up. Nope. This is supposed to be the best time, and by golly, it's going to be the best time. I think age has. Obviously, I'm still waiting to become old, but it's been a surprise to me that this is the best time. Every year is a better one than the last one. And if I have the occasional ache, pain, or torn meniscus, so what? So my hope is that more people, more young people, which astonishes me, are as dedicated as you are to healthcare, because that's what's going to make the difference. That and the rest of us writing every letter, signing every petition, marching every march, doing whatever we can to assist you.
Maureen, when you talk about every year being better than the last one, I mean, clearly you deserve it. I think seniors deserve it. You've given so much to our society, but it's not possible unless it's supported by smart policy reform, so that can continue, right? When you think about your interaction just with your family, your friends, is everyone currently experiencing the next year better than the last, or is it really hard for some of them?
Oh, definitely hard. I was trained in ballet and became a competitive runner and have been horse crazy since I came out of the womb. So I'm fortunate in being in really good shape, except for that touch of COPD because I was a stupid kid and smoked, and the torn meniscus and a few other totally unimportant things. But there are a great many people who are in serious jeopardy. My puny medicine experience, my prescription experience, is nothing compared to people whose life-saving medication is thousands of dollars, tens of thousands of dollars. What are they supposed to do?
No, agreed. We recently did a Gallup survey, and across the country last year, $88 billion was borrowed to cover healthcare expenses. If we look within the population over 65, $22 billion spent from their own retirement accounts to cover the expenses that are necessary for next year to be better than this one.
That's so sad. I saw that on your chart, and it's just heartbreaking.
Agreed. So, Bob, I'll go back to you. It is heartbreaking, yet we still have this partisan divide in terms of how to navigate it forward. How do we break that logjam? Right? I mean, it feels like the solution set is a null set, right? Nothing in it. Right? Every time you try to find something that would sort of meet the needs of Maureen and her friends and so many like them, across this country, we can't find things that we agree on.
Well, Maureen, you're an inspiration. Let me start by saying that. And I love your, you are the antithesis of that overused term silver tsunami, that people worry about, which I think is a rhetorical ageism of the highest order, but that's another subject. But that being said, it's about looking for what can be agreed upon on a bipartisan basis. I happen to believe that the one thing that we could agree on is an out-of-pocket cap for people on Medicare for drug costs. I think that can be done. Okay, I think it could be done in the context of a freestanding bill or part of some other package. But until you reach the point where you can come to consensus, I think back about the surprise billing. Stephen, you remember that very well last year, the surprise billing legislation that came, went, disappeared, came back, got knocked out, came back, ultimately became law. Well, that ultimately was because people were doing what Maureen just did, telling a story, putting a number, putting a face on it. Because I don't care, there is no good policy without politics in this country. Okay, and the way you talk about politics is you localize and humanize the most complex issues down to where they can understand it at the local elected official level. So I think we should look first at what we can do about putting a cap on out-of-pocket costs, see if that can be met on a bipartisan basis, and then build from there. The problem, I think, in this discussion is everybody thinks they got to do the whole thing all one time. That's not the way the process works. It's incremental. Okay, but you got to start somewhere, otherwise you have no momentum to go deeper.
Bob, I just I agree that you can't look at sort of the totality of the problem and solve it all at once. Just thinking through sort of drug costs as an example, I think it's as we sort of one of the non-negotiables I would suggest is that we need to look at inspiring people like Maureen and those like her that can be challenged by the high cost of drugs, and one way to get that is sort of cap the out expenses, the top expenses. But we also have to think about total national healthcare expenditure, right? We can't just shift these costs, right, from an individual to a payer or to the industry or to the ultimately the government. We need the trajectory of spend to come down. Can you just comment a little bit on how we should think about sort of balancing the cost to an individual versus the cost to the aggregate system and to society? I
like these simple questions you pose, Tim. But let me say this. First of all, we should be discussing the difference between essential drugs and non-essential drugs in the prescription area. Okay, we should not impose price controls on the protected classes of drugs. Okay, they should be sacrosanct from any discussion. However, we can certainly look at ways that there's a lot of people who take drugs that they don't necessarily need. They take it for reasons that may not be crucial, if you will, but we're spending money on it. I think if we stop some of the advertising that we see that encourages people to pursue drugs that maybe aren't that necessary for them, we could maybe make some headway moving into that. And I also think that one thing the government really does need to do, we have a low-income subsidy system program in Medicare Part D for people who have low income who need assistance. Do you realize that the proportion of Part D enrollees who receive low-income subsidies has decreased from 42% in 2006 to 28% in 2019? Well, prescription drug costs have not decreased in that time period. So we need to be putting more resources into those programs that people are eligible for. Low-income people could get relief, but they need to be promoted in such a way that people know they exist. So those are a couple of quick thoughts, but it's a complicated issue, as you well know. But as you also well know, and Wes knows, you guys are on the case. You've been on this case for a long time. You're looking for solutions. You're approaching it the right way, but it's going to take constancy of commitment, advocacy, stories, and making it a political issue more than it is now.
Stephen, I'll go back to this concept of sort of non-negotiables, right? When we think about transforming our healthcare system, certainly, a lot of the work at West focuses on projecting care outside of the hospital into the community, right? For much more sort of, deliberate sort of tethering, of, an individual, their family, the community, to achieve broader health, right? But the system isn't incentivized for that right now. Under a fee-for-service system, if you're a hospital, what you want is the hospital to be full with the most profitable patients, right? In terms of the reimbursement for those procedures, and you have very little incentive to project care or even have care in the community other than to feed your hospital, right? To sort of feed the beast. That's what you do. I'm just curious on your perspective on how important is it as we think about non-negotiables and transforming our healthcare system to move beyond the four walls of the hospital and establish much more trustworthy and proactive relationships with communities as a way of ultimately improving high-value care and outcomes.
Yeah, I think that's incredibly important, and particularly I'm a geriatric psychiatrist, so as I think about that challenge, obviously in the mental and behavioral health space, but I think it's crucial, it's critical, and I think it's where we need to shift. There have been some plans and some discussions about specific emphasis on new models in terms of primary care access and primary care models, thinking a little bit about kind of home-based solutions, so directly facing kind of programs and solutions in a home-based setting. So whether it's home-based primary care or other types of models, and thinking again for ourselves in terms of the innovation and expansion of telehealth services in some way. So thinking a little bit more broadly about ways to really meet the needs of people and communities. I see that in my clinical practice, the challenges that my seniors face in accessing primary care, specialty care. I see that with my own family members, helping my parents, who are both seniors, navigate their complicated kind of medical problems. So I think that's important for us to make that shift and to look at more effective and innovative value-based models rather than the traditional models that we don't serve our patients well, specifically, don't improve their health and lead to better outcomes, and obviously are higher costs, not only for them in terms of their out-of-pocket costs, but also for other payers, federal and commercial and others.
Stephen, you mentioned telehealth, and it's impossible to talk about projecting care into the community without talking about telehealth, right? And certainly, COVID was a natural experiment on that. I go back to what Kim said, right, in terms of the COVID experience for seniors and the digital divide, right? Really, a striking contrast between those that are connected and those that were not. And I think about broader health we need to think about mental health, right? And so, just as we think about, sort of expanding telehealth as part of, sort of an integral part of how we deal with the overall health of an individual, how should we be thinking about sort of the role of telehealth for mental health, right? And, is the digital divide for seniors just too great, or are there ways that we can think about breaking that down in terms of sort of, legislation to support that, or, sort of loosening regulations?
Yeah, I think the first step, obviously, to broadening the digital divide is to kind of close the broadband infrastructure gap. So I'm here in Texas, a very large rural state, and you might imagine not everybody has access to high-speed internet. So I think that's number one, and hopefully the infrastructure plan that's being discussed can get some traction and some momentum in order to ensure that all Americans have access to high-speed care. So a lot of the care that we provide as telehealth is actually telephonic in most cases, which can be helpful, right, to have some access and some contact directly with patients, their families, and caregivers. But obviously, having that image and direct care through other video teleconference kind of measures is important to build and sustain programs. As far as the mental and behavioral health services side, I think it's important for us to recognize what types of services and treatments are available through that. So ensuring that we have a robust service, robust kind of list of services. So psychiatric services, thinking about psychological services and other psychotherapy services, thinking about access to case and care management, work with social workers, thinking again for those who struggle with addiction and thinking about substance use disorders to ensure that there are adequate recovery services that support those issues and those diagnoses. So it can be very complicated when it comes to mental health because obviously we have issues with workforce. We have a large amount of stigma still in our culture to kind of work through, but being able to provide those access to our seniors and others is incredibly important as they deal with some of the things that are commonplace within the pandemic. So isolation, loneliness, disconnection from family and other contexts. So I think people are struggling, and we do see that with surveys out there that from the CDC that looked at the rates or incidence of depression and anxiety in the midst of this pandemic. So very critical. I also think about, to that point, we talk a lot about, obviously, the physical manifestations of COVID-19, but if we think about the psychological impact, so the trauma responses that certain individuals are dealing with, the complicated grief, bereavement, and loss that people are dealing with, in addition to other kind of psychiatric diagnoses, so anxiety disorders, depressive disorders, trauma-related disorders. It's important for us, again, to keep that a part of this conversation as we're continuing to obviously talk about expanding vaccinations and access, but also thinking about the psychological sequela that may have manifested as a result of this large national pandemic.
No, that's great. Completely agree. As we think about landing this plane, to go back to that analogy, I'm going to go to Bob and then Maureen. Bob, you mentioned you don't have to eat an elephant in one bite. You can eat it a bite at a time. There's this balance of how much we take on, but clearly the need is very significant, right? The human impact, that high costs are having in a dysfunctional system, right, are simply unacceptable. First to you, Bob, and then Maureen, my question to you will be, and what would you say to those, sort of those in Congress as they balance this? But how do we think about balancing reform that's too bold and doesn't get done versus, singles that just don't fundamentally have an impact, at a human level, at an aggregate cost level that are necessary?
Yeah, and that's going to be a big issue that's going to confront this Congress for a while, because they have responded well to needs related to the pandemic. I mean, the passage of 4 different emergency bills in a bipartisan way, for the most part, was pretty remarkable. That's not usually the way business is done in this town. But it's the downside of, or not the downside, but the downstream impact of the pandemic that we have to address. So Stephen raised a very important point, and I know you care about this issue too. The whole issue of social isolation and loneliness. What we ought to do, this is not a new issue, but it's been exacerbated by the pandemic. Okay, this should be viewed as a public health emergency and declared as such. And we should move in that direction. I'll give you one example, as Maureen talks about a personal story, I was in Missouri on Friday visiting what was a congregate nutrition site. And the woman was telling me about how of the 20 people they lost in this pandemic this year, of their members, only 3 died from COVID. The other 17, according to family members and accounts, were related to isolation and loneliness and the impact of that on their health. So if we don't think that's a serious enough crisis, we need to address it right away. That can be done incrementally, but we need to first understand the need to go back and distinguish between an expenditure and an investment. We need to invest in public health like we've never done before because of the failure to do so before. So let's start thinking in that direction. Think about COVID downstream. What do we need to do right away to prevent this from the future? And maybe we start there.
Great thought. Maureen, I want to sort of end with you. How does this conversation land on you in terms of, your optimism or pessimism for the coming years to be better than the previous? And, what would you say to, those stakeholders in Congress that are grappling with how bold to be with the next package that we move forward?
It's an excellent question. I have to confess to not having a great deal of faith in many of our members of Congress, but I think we ourselves need to be absolutely relentless in our pressure. Bob was saying that pressure makes laws, essentially, and I think that's true. I think the mental health component is vastly underserved. There are a couple of websites, I believe, that I can't think of the names of them, that you can go online and reach and discuss your mental state of mind. That's a good thing. But we need, what everybody is kind of edging toward in this discussion is a systemic approach. We need a systemic approach in many areas of American life, and this is certainly one of them.
Maureen, I totally agree with you. The stakes are too high for us not to have a systemic approach, not only in reforming the fragmented healthcare system, but I think we also need a systemic approach to keeping the pressure on every single front. I agree with Bob. This is a public health emergency. The stakes are simply too high for us to go back to business as usual. So as we land at the top of the hour here, I'd like to thank Stephen and Maureen and Bob for joining me today, as well as Shelley and Kim for the great discussion on the master plan. I do think the discussion is different, both within households and around family tables and in communities, and hopefully it will be different in this Congress as well. But I think it's all of our responsibilities to continue to engage, to continue to put pressure, and to continue to demand nothing short of sort of meaningful and transformational change. So thank you, everybody.